64-year-old man presented with sudden onset headache, sudden severe headache while watching TV, associated with nausea and vomiting in multiple episodes. GCS on arrival was 14, E3, V5 and M6. So he's obeying commands and opening eyes to voice, and he's oriented to time, place and person. The pupils were equal and reactive and no focal neurological deficit. The patient doesn't have any weakness or any sensory deficit at all. The patient has background of hypertension. Blood pressure on arrival is systolic 181 and diastolic is 122. There was clinical concern for subarachnoid hemorrhage or any other intracranial event from the emergency team. What's a differential diagnosis and what the investigation should be performed? So you have a 64-year-old male patient coming with thunderclap headache, which is a sudden severe acute onset headache. So your top differentials in that case should be a subarachnoid hemorrhage, a spontaneous aneurysmal subarachnoid hemorrhage until proven otherwise. However, there are other differentials as well, including your intracerebral hematoma. You can consider a stroke as well as one of the differentials, despite our patient does not have a neurological deficit. You can also consider an intracranial mass or an intraparenchymal mass. And finally, you can also consider migraine as one of the differential diagnoses, and encephalitis or meningitis could still be considered. However, your top differential should be aneurysmal subarachnoid hemorrhage. You should also stress, given the acuity of the presentation, stroke and subarachnoid hemorrhage is the top differential diagnosis. The CT head was done. What's the diagnosis? As you can see in the CT scan, and also identify the AROD structures. As you can see here, there are two different sections of an axial cut of a CT scan. The most obvious diagnosis that you can see is subarachnoid hemorrhage, as you can see here on this side, and also early acute hydrocephalus. You can see the temporal horns are increased, which is number 12 on both sides, and also the frontal horn and the occipital horn are dilated with periventricular permeation of the CSF or transependymal permeation of the CSF. You can see the hypodensity around the ventricles in all the directions, and that suggests that this patient has acute hydrocephalus and also a subarachnoid hemorrhage that's dispersed into the basal cisterns, the sylvian fascia, and the sulci on the right side. To identify the structures, number one is the subarachnoid hemorrhage in the sulci in the right hemisphere, and 2 is the frontal horn, 3 is the occipital horn, and 4 is the third ventricle, and 5 is presence of blood into the occipital horn of the lateral ventricle, and number 6 includes the transependymal flow due to acute hydrocephalus or the transependymal permeation of CSF. And 7 is your sylvian fascia on the right side, and 8 is the interpeduncular cistern, and 9 is the ambient cistern, 11 is the quadrigeminal cistern but doesn't have any blood in it, and number 10 is the ambient cistern on the other side, which is in the left side, and 12 is your temporal horn, which you don't normally see in a normal CT scan. But when you see it, it suggests that the patient might have acute hydrocephalus as one of the differential diagnoses that you should consider. What are the causes of subarachnoid hemorrhage and what is likely cause in this patient? So generally, the cause of subarachnoid hemorrhage is traumatic and spontaneous. Traumatic actually represents about 80% of the cause of subarachnoid hemorrhage. Spontaneous subarachnoid hemorrhage is caused mainly by aneurysmal or patient who has an arteriovenous malformation or any other malformation that can lead to subarachnoid blood. The likely cause in this patient is actually an aneurysmal subarachnoid hemorrhage. Given the distribution of the blood, I would consider it very likely a right MCA or middle cerebral artery given the presence of the blood in the right sylvian fascia. So traumatic and spontaneous and distribution suggest a ruptured aneurysm on the right MCA. The grade of subarachnoid hemorrhage in this patient, there are 2 different types of grade you can use in aneurysmal subarachnoid hemorrhage patient, which will be mentioned later on in this video. Those 2 types include one, the WFNS score, or the World Federation of Neurosurgery scale, and the fascia grading, which is a radiological grading. WFNS score should really be calculated as soon as you treat the seizure and also as soon as you treat the hydrocephalus. So in this patient, WFNS score doesn't really apply. But if you are to apply it, you have a patient with GCS 14 and there is no neurological deficit, so it's WFNS grade 2. However, as I mentioned, this patient has acute hydrocephalus and you shouldn't really consider doing the WFNS score until you have treated the hydrocephalus. On the other side, the fissure grading, the modified fissure grading, this patient is going to be fissure 4 because you have an intraventricular bleed and subarachnoid hemorrhage that is thick, which is more than 1 centimeter thickness if you go back to the CT scan. So WFNS 2 and fissure 4. What are the general measures that need to be instituted for a patient with aneurysmal subarachnoid hemorrhage? So generally, what you're worried about in a patient with subarachnoid hemorrhage is that they might have a ruptured aneurysm and the risk of rebleeding is actually very high. And also the risk of hydrocephalus is extremely high as well. The risk of vasospasm. So you have multiple complications that you need to consider. So therefore, if this is a referral from a DGH or another hospital, this patient needs to be urgently in a neurosurgery center where they are able to treat the aneurysm and also treat the hydrocephalus urgently if required. So a safe transfer needs to be arranged as soon as possible. This patient also needs to be in bed rest. You're worried about vasospasm, so you need to consider giving a patient nimodipine. According to the trial, we give nimodipine from day 1, from the ictus, from day 0 basically, to the day 21 to prevent the vasospasm. You also need to give some good painkillers because actually pain can increase the blood pressure and does increase the risk of having rupture of the aneurysm. Also consider giving them laxatives because constipation can again increase the intra-abdominal pressure, their blood pressure can go high, and therefore they can end up having a rupture of the aneurysm or a rebleed of this aneurysm. After doing all of this with transfer to the neurosurgery unit, you need to consider discussing with the patient the diagnosis and actually confirm the diagnosis by getting a CT angiogram and considering a digital subtraction angiography. And after doing all of that, you discuss the management plan, which is either endovascular treatment of the aneurysm or a clipping of that aneurysm, which is an open surgery. So the general measure you need to consider: transfer to a unit, book ICU for the patient, bed rest, do all the bloods, pain management, lactulose, DVT prophylaxis. You cannot really give prophylactic low molecular weight heparin at this stage, but you should consider mechanical prophylaxis and blood pressure management, which I haven't mentioned. You should aim to keep the systolic blood pressure on the low normal side. The specific measures you can institute is basically hydrocephalus management and also blood pressure management. Keep it in the low normal. The following day, the patient had catheter angiography, which showed right internal carotid artery aneurysm, internal carotid artery injection. And as you can see here, this is on the right side. Number A is the ICA, B is the ophthalmic artery, and C is your ACA or anterior cerebral artery, and D is your MCA, middle cerebral artery. And the middle cerebral artery divides into superior division and the inferior division, and you can see the aneurysm is just at the junction of that division. And F on the other side is the continuation of the ACA or anterior cerebral artery. Management of this case have changed with the following CT scan. So look at this CT scan, which I don't actually have here. So I need to consider adding this.